start the discussion about India and the COVID-19 pandemic and economic perspective. And
Right.
I would like to start with our first question.
Mm-hmm.
In the present context of neoliberalism and the experience of the last 3 decades, what is your assessment of India's public healthcare? Are we suitably equipped to combat the COVID-19 crisis?
Thank you, Saket, for asking that question and also asking me to come and speak to you. Let me answer your question in three parts. You are sort of asking me what is the state of health. So I would start with looking at what has been the framework of policy making in India, which is, the neoliberal policy framework, how it has impacted health at second level, and therefore what challenges it poses for us to deal with a pandemic like COVID. So let me begin by saying something about what is the neoliberal policy approach or a policy framework. And then I'll come to the second part of what it means in terms of applying that principles to the sector of health. Neoliberalism as a concept is essentially a set of ideas that informs policy making in large parts of the world and in India, particularly since mid-1980s. And it's an approach which favors free play of market forces and minimal role of the state. So it often goes up to the extent of withdrawing any welfare measures that the state may have implemented with it before this policy paradigm became dominant. It is also characterized by free trade, deregulation of financial markets, privatization, individualization, and so on and so forth. And state no longer believes in taking the welfare of its people as its primary responsibility. In fact, the state wants to focus more on productivity, efficiency, increasing output, and the ideas for social justice, ideas for social equity take a backseat. And the state believes that once it promotes these efficiencies and competitiveness in the markets, and there is generally this buying and selling that takes place, that itself will bring in the long run the welfare of its citizen and its people. So to put it, just as an example, assuming that my children did not get access to education, or you were not able to get access to health services, then perhaps the failure in this policy outlook would be yours. Though essentially the fault is yours, that I cannot afford education for my children and you cannot afford health care. So people who fall behind become defined and self-defined as losers. That's essentially the approach that this policy looks and applies. And the state then may take some responsibility in a paternalistic sense as my bap to sort of address the concerns of those who cannot get access to education or health, in my example. So this is the larger framework of policy making which has dominated India since mid-80s. And the more specific question is how this approach or how this policy paradigm has influenced health provisioning in India, or by and large the health sector in India. And I want to answer that question by addressing four issues on the question of health. First, how health priorities are decided within this framework, within the neoliberal framework, how health priorities are decided. Then once health priorities are decided, how the money is spent, that is the modalities and framework of spending this money, how much money is spent, and as a consequence of these three, that is the decision about priorities, the mechanisms of spending money, the quantum of money, how all these three then influences the health outcomes and accentuates health inequalities in a society or in a country like India. So in order to sort of lay down in front of you the canvas of health in India, I want to deal with these 3 or 4 issues. Now, it's well known, if you look at the literature, that neoliberalism has led to deep changes in healthcare systems. So in other words, neoliberalism has affected healthcare as a sector and as a system far more substantially than compared to many other sectors. And on account of this emphasis on markets that neoliberalism builds, the right to health of citizens has taken a backseat. And this has happened in India in a big way. It's happened in other parts of the world as well. And this withdrawing of availability and access to health as a right and provisioning of health through the private sector and through the market has accentuated health inequities and health stratification of health services to a considerable extent in India. The belief is that if you can't be a claimant to buy private health facilities, then you need not get the health facilities. It's not said so bluntly, but that's the outcome of the policy framework, the way it has been implemented. Bulk of the health services are provided by the private sector, and in the public sector itself, user charges are introduced. Government expenditures on health are very low. So this is the broad approach that we have adopted when we look at what we have done as a result of the influence on neoliberal thinking, on the health sector. So the first question, how health priorities are decided. Now, it is interesting to observe that it is very difficult nowadays to link the state of health in India with the priorities of state or the priorities of the government in the health sector. And there is, in fact, a disconnect between the two. And let me give you an example. If you look at the disease burden in this country, and if you look at the health priorities that ensue from this disease burden, then you will find that the health priorities that we have chosen does not match with the disease burden. In India in 2018, the National Health Profile provides this data quite comprehensively. The numbers suggest that we have about 1,31 lakh cases of acute diarrhea in India, 4,19 cases of acute respiratory infections, about 1 lakh cases of dengue fever, 9 lakh cases of pneumonia, and many other numbers are there for neonatal tetanus, for chikungunya, and so on and so forth. Now, if you look at the diseases that I have just listed and the numbers, you can clearly see that many of these can be addressed if we had a public health approach towards the health sector. But we do not get that kind of focus on community factors and on general water sanitation and infrastructure factors that could influence health outcomes on such infectious diseases and the numbers that I have listed. There are a number of studies where we find that, just to give these numbers in another perspective, if you were to apply the rates that are available to us today, then the number of people that would have died yesterday, I want to give some of those numbers. So if you look at respiratory infections, not COVID, 938 on an average people would have died yesterday, diarrhea 1,421, fever of unknown origin 928, tuberculosis 1,026, and malaria 508. So essentially about 4,000 people are estimated to die every day because of the diseases that I have just listed. And none of us seems to be worrying too much about it. I'm not undermining, the crisis and the pandemic of COVID has created. But what I'm saying is that these everyday diseases, which affect thousands and thousands of people, by now should have produced in India, in terms of health care providers, large number of doctors, virologists, epidemiologists, public health professionals who would be helping us dealing with these, on an average, 4,000 deaths coming from, bad water sanitation and, other conditions which precipitate infectious diseases. But this is not treated as a public emergency. I mean, we don't talk about these 4,000 deaths on an everyday basis. If you look at the non-communicable diseases, the numbers are suggesting that that's a dominant cause of death today in India. About 62% is non-communicable diseases. About 5.2 million people lose their life because of these diseases. Heart disease is the leading cause of deaths in India, followed by cancer. Both are non-communicable diseases. Both of these diseases are on the rise in India. In fact, India has witnessed a 50% increase in heart disease in the past 25 years. Similarly, for cancer, India has one of the third highest number of cases in the world in cancer, behind China and United States. Cancer rates are expected to double by 2040 to around 20 lakhs from about 11 or 12 lakhs in 2060. As you would notice, as we have talked about the communicable diseases, even on non-communicable diseases, if we look at the factors that are responsible, we are unable to address those factors. So basically, a community approach to health, a public health approach to health is not being adopted if you look at the patterns of disease burden in this country. Between 1990 to 1916, if you look at infectious diseases, about 5 out of 10 deaths in India belong to this group, and these are just the averages. There are large variations across the states. Between states, the numbers vary for each of this. For example, if you compare the lowest state and the highest state, there is a 9-fold difference in diarrheal diseases. There is a 7-fold difference in respiratory diseases. So what I'm suggesting is that not only that the averages are high, there are regions in India which have where the numbers are even much larger than these averages. If you look at India as a whole, the rate of diarrheal disease and iron deficiency, anemia, and tuberculosis was 2.5 to 3.5 times higher than the average globally for other geographies at similar levels of development. I am giving so many numbers to put the disease condition or the morbidity conditions in India in a perspective, to say that what kind of an approach it demanded in the health sector to deal with this kind of health emergency and the health crisis. So in spite of this, the health sector in India, given this burden of health, of diseases, is still characterized by huge staffing shortages, for example. Now, why do we experience staffing shortages? Why don't we have the epidemiologists or virologists or public health professionals? Because we believe that the health education has to be provided by the private sector. There is barely any expansion of teaching of, creation of health professionals who are funded by public education. Bulk of this education is available from the private sector. Why do we make that choice? We made that choice because we believed in a policy framework where we did not depend on the upon the public sector, and we want to depend greater and greater on a private sector. And not only education, but provisioning of health also. Between 1996 to 2016, in terms of, if you look at the provisioning of healthcare, the private sector is the one which has expanded and which is providing bulk of health services. In 2014-15, 68% of the hospitalized cases in urban areas were catered by private sector. 42% of the hospitalized cases in rural areas were dealt with by the private sector. 30 years of structural adjustment has essentially created conditions where public hospitals, public beds are very limited and have barely expanded. There has been some public expenditure, but that has essentially focused on maternal and child care. And the result of it is that at the primary level, we barely have facilities for public health. And these facilities are now going to be crucial for COVID, and I'm going to come back to it in a minute or two. If you look at why this has happened, the second question I wanted to address was our approach to public expenditure. We expend close to about close to 1% of our GDP on health as far as the central government is concerned, and which has resulted in high quantum of out-of-pocket expenditures. In other words, if you look at the household expenditures, the expenditures on health is a very large proportion of their income. And bulk of the expenditure that we make, more than 60% of the expenditure that we make is private expenditure in terms of, on health in India. If you look at the consequence of these low public expenditures and high private expenditures, the consequence is that it drives millions of people into poverty. 55 million people find themselves in this situation because of the medical bills to be running into poverty. In fact, some journals are suggesting and some studies are suggesting that out of these 55 million people driven into poverty through medical payments, 38 million were placed due to out-of-pocket expenditures. So the out-of-pocket expenditure is very high. That is, household expenditure is very high to deal with this. There are other numbers, for lack of time I cannot establish, but this is a major source of indebtedness across households, and the number of indebtedness that this expenditure causes, just to put it in perspective, in rural India, every year is equivalent to the population of Uttar Pradesh. The government has chosen, the strategy to respond to this high levels of indebtedness in health has been to come up with insurance program where these insurance packages are paid by the government for the poorer household. Earlier in 2008, we introduced the RSBY, which is the Rashtriya Swasth Bima Yojana, the National Health Insurance Program. And this has been in place. It covered, the coverage was about 30,000 rupees for hospital charges. Now, since it has been implemented since 2008, we have a lot of evaluation studies to see look at the experience of these schemes. And if you look at the evaluation of these schemes under the RSBY, the numbers aren't, or the outcomes aren't very impressive. And in spite of this, experience of the RSBY scheme, the current regime and the current government has come up with a program called the Ayushman Bharat National Health Protection Mission in 2018. Now, what was the context when this scheme was introduced? The context at that point of time was, if you look at the national health accounts, that 67% of the total health expenditure came from household pockets at the national level, which was roughly around 3,800 rupees, out of which 2,400 was an out-of-pocket expenditure. So you can imagine that a large percentage of household expenditure was coming from their own pockets. And this was the source of 7% of population falling below poverty every year. When these were the numbers in 2018, the government came up with a scheme called the Ayushman Bharat. And the Ayushman Bharat is basically aims to cover poorest 40% of Indians through a medical insurance program, whose limit has been increased to 5 lakhs. Now, the choice of insurance as a method to deal with indebtedness of households as a result of health expenditure, and also given the patterns of morbidity that we talked about, actually it does not give us a future where the challenges of health would be covered. One of the key challenges of the poor household is that the large chunk of their expenditure in the out-of-pocket expenditure is in outpatient care. And these schemes are covering hospitalization. So the outpatient care is not covered by these schemes. And poorer households tend to minimize hospitalization, because if they go to hospitals and get admitted, then they lose their daily wages. So in a situation like this, the modalities that we have adopted as the Ayushman Bharat to deal with the morbidity patterns in India and to deal with the specificities of the poorer household in terms of their morbidity and in terms of their requirement to deal with outpatient care, the potential for this scheme to really give benefits in order to reduce the levels of indebtedness as a result of health expenditure that we talked about is very limited. But we continue to insist with these modalities of dealing with the health requirements of this country because of the larger belief in private sector solutions and not having a public and a community sector solutions to the problems of health in this country. Now, the consequence of this approach to health has resulted into, as I was talking about earlier, has led into increase in inequities in health, and also non-impressive performance or very poor performance on large number of indicators when you compare India with other lower and middle income countries. There's not enough time for me to, but I'm talking about life expectancy here. I'm talking about under 5 mortality rates. I've talking about risk to health. I'm talking about quality of care. On all this, I'm talking about beds per 1,000 population. On all this, India is either just close to the average for lower and middle income countries, particularly in Asia and Pacific, or is just marginally above. And in large number of these indicators, it's actually worse. Life expectancy at birth by gender, gap in infant mortality rate between the highest and the lowest income households. In all this, India's performance is not impressive, even when we compare India with the similar levels of income across countries. Now, health inequities also in terms of some recent studies looking at health inequities for women across range of factors between 2015-16 shows that the inequalities has increased across income, inequalities are between rural and urban areas, inequalities has increased in terms of those who live in the where medical facilities are available in terms of distance, it has increased in terms of educational level. So essentially, you can see that the marginalized and vulnerable population are at disadvantage in this approach to health. On this canvas of health, you have now India going through a pandemic like COVID. We do not really know where, how long, in what direction COVID would unfold. Only public health professionals would know. But one thing we know, that the current strategy and the current lockdown, the quarantine and the social distancing that has been implemented is intended to give us time. So it's essentially a very busy time. At one level, people are in their houses or people are under lockdown, but it's actually a very busy time for the government. And it ought to be a very busy time for the government, because this time must be utilized for putting systems in place, for creating the provisions such that this pandemic, as it unfolds, it can be dealt by the health infrastructure in this country. So this is the time to increase the provisioning of healthcare in this country in high proportions. And we do not have any information of whether that kind of planning is being put in place in India or not. Since we have already discussed the situation of health in India, we know that at the moment, the only agency which can address a pandemic like COVID is the government. So it basically, public provisioning is the key to deal with the challenges that COVID imposes. We need to ensure that minimum fatalities happen as a result of COVID, for which we need to create facilities for critical care. So roughly, if 50% of the population above 30 years could get infected, out of which 4% needed critical care, we are looking at least 20,000 persons in a district of a 2 million population to deal with the crisis for COVID. Now, the health response to COVID is at two levels. Response that deals with what individuals can do about it, that is individuals like you and me, in terms of how we maintain basic sanitation, basic hygiene, and so on and so forth. And the other is in terms of the provisioning that I was talking about. Now let me come to this individual bit. So when we think of policies which require awareness at the individual level and certain responses at the individual level to think of COVID, we need to think of the large mass of working population in India, section which does not have any sick leave, section which needs to work daily to earn its income. When they experience symptoms of cold, or they need to have maintain social distancing, or they need to maintain basic hygiene and sanitation, how do they deal with COVID, with these requirements, and not only the rich and the well-off? Right. So this requires large facilities for primary healthcare to be created for dealing with both the larger provisioning when the critical condition comes for COVID, as well as to deal with the requirements for this individual provisioning as well. The urgent need will be to establish ICUs for critical care, ICUs with ventilators, with oxygen, for at least every 5 to 10 lakh population. And we are far away from these numbers. So if we want to use this time, we need to focus on creating opportunities and facilities for individuals, so that their hunger, their living conditions, their hygienic conditions are such that they can implement the norms that can safeguard them from COVID, as well as we need to create public facilities for critical care once COVID unfolds. Unfolds at a big scale in India, because I think the pandemic cannot be killed. We cannot fight a war with pandemic. What we need is a strategy to deal with. हमें युद्ध नहीं चाहिए, हमें strategy चाहिए, समझ चाहिए, सोच चाहिए to deal with this pandemic. It's not a war. We don't want to kill it. We want to deal with it in a manner where minimum loss of life and minimum loss of any other kind of livelihood and others happen for the citizens of this country. So when we are going about implementing this COVID and looking at this issue of public health and public health approach towards addressing COVID, there are a large number of things that the government must not fall prey to, but which as we are experiencing, that it is that we might not be, unless we underline those issues, we might end up doing exactly those things which we are not supposed to do. For lack of time, I'll not elaborate on this, but we must be very careful that when we call for responsible behavior of population, we should not go to any unreasonable restrictions on people's movement. We should not use repressive means to deal with mass quarantines, because that will have adverse consequences on the poor. We should not blame the poor for their irresponsible behavior, because that is going to be unfair and unhelpful. we should not be doing any of these things. Already there are instances of violence against the migrants and immigrants and the marginalized sections of population. They talk about, accusing a particular gender or a particular geography or a particular ethnicity as drivers of COVID. We need to avoid those errors because if these trends grow, then we will not be able to comprehensively address COVID with a public health approach that we had talked about. And the last point is that when we're talking about quarantine, which is an important component of public health approach to COVID, historically, conditions under quarantine have always required independent monitoring by civil society and human rights organizations to protect rights against a state that empowers itself with huge and often unnecessary powers under the epidemic acts. And we have to be very careful in India also that we don't make that mistake. Self-quarantine backed by local communities and social support is required, and the quarantine and social distancing should not mean that under the epidemic act or a disaster act, the state gets more teeth and more power without really contributing to dealing with a public health and a public emergency approach to this infection of COVID. Helplessness of the existing patterns of development that we have experienced as a result of this pandemic, I think is in one line, is the major lesson that COVID has taught us. COVID has taught us that the negative consequences of urban growth, of globalization, is something that the kind of policy frameworks and development approach we have adopted so far is not going to address. We need to think again, to think afresh, and business as usual approach of economic, social policy, and health policy will not work to deal with a pandemic like COVID.